Yeah, there are still a couple of members to join, but we are okay to go when we get to 10 minutes.
And good morning, Joe.
Morning.
Okay, I make it 10 o'clock. So if everyone's happy and if we're good to go, Rebecca, are you happy that we go forward?
Yes, please proceed, Chair. Thank you.
All right, thank you very much. Well then, good morning, everyone. My name is Anita Day. I'm Chair of Worcester Acute Hospital NHS Trust, and I'd like to welcome you to this morning's meeting. It is Thursday, the 13th of October 2022, and this is a meeting of our Trust Board in public. I'd like to extend that welcome not only to members of the board and our guests today, but also to anyone who is watching us on YouTube via the live stream or indeed on the recording later. Very much appreciate your attendance. Okay, we've got another really interesting and important agenda this morning. And as always, I'd like to start with our patient story. We're really clear as a trust that that's absolutely the right place to start. I think many of you will know that we focus on our strategic pyramid as our North Star, the thing that directs everything we do. And what I love about the story that we've got today, that it actually epitomizes many of the things that we talk about in theoretical terms, a lot of in one story. There's very much a clear focus, as you'll hear, on putting patients first, about actually putting decisions that were right for the patient at the centre of everything that happened. There's absolutely something about our vision of working in partnership, of teams from different parts of our organisation coming together to say, okay, what is the best way for us to care for this patient? It speaks to our strategic objectives about best experience of care and about best use of resources. And then finally, and as important as all of those things, it's a story that talks to us listening to the people on the ground who understand this stuff best and valuing their expertise and experience to really direct and influence how we look after patients. That's at the heart of our forward improvement system, and as I say, this is a story that ticks many boxes. Without further ado, I'll hand over to Paul. Thank you.
Thank you, Chair, and good morning, everybody. Firstly, can I introduce Claire Alexander, who's the matron for cardiology, and Sarah Grave, who's the sister in the cardiac cath lab. So welcome to them both. I'm not going to talk about the story because that's their job. So obviously Claire will start, and then Sarah will share the impact on her and her role within the unit of this particular case. And then there'll be opportunity for questions. So without further ado, I'm going to hand over to Claire. Thank you.
Good morning, everyone. I think I just want to start by saying thank you for inviting Sarah and I this morning to share our story with you. After 14 years in the trust, I think this is the first time I've brought a patient story, which is really probably quite shocking, but we're really pleased to be here today and to tell you about this particular patient's journey. So I think this patient story and the opportunity to share it came to light as a result of the Denver walk round that Paula did in cath lab, which was really valuable. And we were just able to really talk about what the work we do in the lab. I think it's a great example of, as Anita said, of putting patients first and of navigating capacity issues. So as an overview, I was in A&E one morning, as I am with my colleagues a lot of mornings, and with no specific agenda other than to see how A&E is doing, what we can do to support, who can we pull directly. Through talking to the A&E sister, I became aware there was an elderly gentleman who was coming in. Capacity was very tight in the department. It was likely he was going to be on an ambulance outside initially, which is not what we would want. And he came in with a low heart rate and a fall, so I immediately flagged that as something that actually might be for cardiology and might necessitate a pacemaker. His normal place of residence was a nursing home. He's a gentleman with a past medical history of dementia, so obviously there was a lot of factors going on there for this chap. I then flagged it to Sarah, who conveniently is situated just off of A&E, as this might be a patient that we can really pull through and get into the department very quickly and get him treated and shorten his length of stay and improve his patient experience, really. I think we know as part of our frailty plan that it's very much about putting the patient first, which we do with all our patients, but it's about treating the patient as an individual and actually flexing up the system to meet the patient's needs, not the patient meeting our system needs. And that was very much our focus. I'll pass over to Sarah to talk about the logistics, but I think it's a great example of empowering staff to work flexibly, and also looking at ways that our system can flex. And again, it's about us flexing around, and there's huge opportunities for that. So I don't want to take the credit. Sarah did all the hard work, so I'll pass over to her to talk about what she did.
Morning, everybody. So Claire asked me if I would just keep a lookout for this gentleman when he arrived in the ambulance. So when he arrived, there was still no capacity in the ED department. So I spoke to the nurses and actually went to assess the patient in the back of the ambulance, did my initial nursing assessment, and then conveniently one of our cardiology consultants was in the department, so I asked him to come and review the patient, as my initial feeling was that he did need a pacemaker. So Dr. Foster kindly came to the back of an ambulance. He did point out this was the first time he'd ever assessed a patient in the ambulance, but came with me, assessed the patient, made the decision that he did need a permanent pacemaker. So the gentleman was then immediately transferred to our cardiac catheter lab, our day case area, where we prepared him. He had his pacemaker that afternoon, came back and recovered with us, and then was transferred back to his nursing home that night. So that meant that he bypassed ED completely. Normally patients would be admitted on the ward to wait for a procedure, and then depending on the time of the procedure may have further stays in hospital overnight, but by admitting him straight to our department and having his procedure, he actually went home that same day. So we try to work proactively with A&E and look for cardiology patients. They often will come and talk to us, or Claire will signpost patients. We currently treat emergency heart attack patients bypassing A&E, and in the future we'd like to try and treat more cardiology patients to assess them ourselves. I guess assessing patients on the back of the ambulance, if you'd asked me a few years ago, that would have been something that I would have thought was something I would never have done. This is something we do more regularly now. I guess it's a little bit scary at first, out of your comfort zone, but it's about the patient. It's about doing what's right for that patient. The patient was quite scared, a little bit confused in the back of the ambulance. So, me talking to him, bringing the department, having that continuity of care with nursing, just makes hopefully his experience so much better. I think nursing is changing. My role's changed, but we just want to do what's right for the patient.
Thank you. Thank you, Sarah. Thank you, Claire. I think that's a fabulous story. As I said, I just think it ticks so many boxes, and I think that proactivity and that sort of saying, what can we do to make this journey easier for this patient was just shone through. I'm opening it up for questions, and I can see Paula.
So thank you, Chair, and thank you, Claire and Sarah. I nearly got both your names mixed up then. Well done, brilliant story, and well done for putting the patient first. That is just amazing work, and obviously we need to thank Will as well, because he is a really responsive cardiologist, so that's lovely to hear. You did touch on it a little in the story. The patient has dementia and Parkinson's disease. That in itself is quite significant for an individual patient, isn't it? How did you help him, and how did you calm him and keep him calm and explain things when he clearly got nobody else with him that could explain to you what his norm would be like? How did you manage that?
So initially his wife was actually with him in the ambulance, so we did talk to her, and I think it helped a little bit because I'd spoken to him in the ambulance. I then helped to get him ready, and I did recover him for a short while as well, so having that continuity of nursing, but also we understood although he did have some memory issues and dementia, Dr. Foster did talk to him and explain, and to his wife at length, about the procedure, because it is an invasive procedure, and we needed to make sure that he understood what he was going to have done. And through our assessments, we felt that he had understood that. His wife was obviously happy as well, but it felt like the right thing to do, but also not admitting to another area, a different ward. All bed moves we know can increase confusion.
No, absolutely, Sarah. Perfect. That's brilliant to hear. Chair, can I ask a follow-up?
Go ahead.
And I may be encroaching on some of the Neds here, but what we normally say to people who come to board to present to us is, what can the board do to help cardiac cath lab or cardiology in itself? What can we do as a board? Anything?
I think there's a huge amount of potential within cardiology, and we know that, and we're working as flexibly as we can with the resources we've got. I think last year we did more angios in the QE in our two little labs. We know the expansion is kind of on the table, and I think that would give us, if we can make that happen, that would give us such a lot of potential to work differently, to siphon these patients off from the main A&E, get them assessed quickly, get them treated, and signposted to the right places. So I think, there's a lot of opportunities within cardiology, and we're absolutely committed with the right support to make that happen.
Brilliant. Thank you, Claire. Thank you, Chair.
Thank you. Richard.
Thanks, Anita. And it's probably a good example of teamwork, because Paula asked my first question, which was around the dementia, because I was really interested in the ability to make a decision whether there was a relative involved, etc., which is quite important, of course. The second thing is, and maybe this is not so much a question for Claire and Sarah, but clearly I can see the cardiology team is very focused on this type of behavior, which is great to see. From many perspectives, it's been mentioned by people. Do you think there are other areas where we've got these possibilities, and so the board should not just enable cardiology to kind of do this type of approach, but maybe other areas as well? Do you think there are other areas that would qualify this as well?
Matthew, would you like to talk to Paula, you're coming.
Sorry, I will start. Yes, there are, Richard. There are many areas. I mean, I'm not sure. Our option isn't it, to offload the ambulances? That's what we would ideally do, and then those specialities go into the ED to pull those patients through. And cardiology is a prime example of making sure that we actually did that admission avoidance. And there will be other specialisms like frailty, for instance, that we would be looking at to think at the front door. What could we do? Because in the brief that you've got, sometimes admitting our frail elderly, especially with cognitive issues, causes more difficulties to try and get them out the other end. So frailty is another example of where we can stream at the front door and signpost and hopefully not admit and cause more issues going on. But I will leave it to Matthew and Christine to ask if there's any more that they think we could answer.
Matthew?
Yeah, thanks, Chair. Thanks, Paula. I think it's a really important question, isn't it? Because whilst, as Claire said, our cardiology service is on the front foot always at looking at opportunities. The resourcing in cardiology is, in relative terms, in a better position than some of our services. To be fair, Richard, I think the question. Or the point about frailty, I think, is an important one. I know that the urgent care team are really keen and are already planning for a different approach to the assessment of frail elderly people that perhaps are brought in by ambulance, where a different approach might be better. And with the move next month into the first floor of the emergency village in the Aikenbury building, they are identifying some dedicated space for frailty assessment for the advanced nurse practitioners, particularly, and advanced practitioners to assess really whether an admission is necessary. because as we know, hospital-acquired functional decline in the frail elderly is a really major issue across the country. So I think, as Paula says, I think frailty is an important opportunity. I think there's a question mark really for some of our other medical specialties, but of course the challenge is covering the wards, covering the outpatient demands as well, and seeing how we might flex the service. So I think that's a constant area for keeping under review, Richard, would be my summary comment.
Thank you, Matthew. Simon.
Continuing the theme of teamwork, Matthew's just answered my question about the UEC and the potential for doing more of this, so I won't delay you any longer.
Thank you, Simon. I can't see any more hands up, so I think it only leaves me to say thank you again to Claire and Sarah. I think that was a fabulous story. It really is exactly the kind of thing we should be doing, and it sounds like it was the best possible outcome for that patient, and you know, we're really excited and really proud of the work you're doing. So thank you very much, and thank you for taking the time to come and talk to us about it today.
Thank you.
Thank you.
Bye.
Bye.
Bye. Right. So a lovely, inspiring story to kick us off. But let's now get into the body of the meeting. First of all, apologies. I have apologies from Colin Horwath, one of our non-executive directors. I don't have any others that I'm aware of. Rebecca, I'm seeing a shake of the head from Rebecca, so I'll assume not. Okay, brilliant. In terms of items of any other business, I don't think we've had any notified, anything outside the agenda. Does anyone want to raise any last minute things? Again, I don't see any hands, so thank you. We'll assume not. Declarations of interest. Obviously, our general declarations are on the website. Is there anyone that would like to declare an interest in anything specific to today's agenda? Again, I see no hands. Thank you very much. Okay then, let's move on then to the minutes of the previous meeting, which were in the pack of papers. I wonder if we can approve those as a true record of our meeting, our last meeting. Again, if anyone could raise their hands if there are any concerns or anything that they want to raise in respect to those minutes. I had only one thing, Rebecca, and that is they appear to be signed by Sir David Nicholson, so maybe that
Yes, no, apologies. Paste in the pack. No, we'll get that amended for you. And yes, we've noticed another eagle-eyed board member had spotted, so yes, we'll get that amended for you.
Lovely, thank you very much. Any other comments? Are we happy to approve those as a true record? I'll take some, that is yes, so thank you very much. The action log, Rebecca.
Yes, thank you, Chair. We've been able to close a number of items this month through actions that are already on the agenda or things that have taken place. Two of the items are due for update in at future board meetings, so you can see that we've got an invite one of our network colleagues to come along and join us, which will be excellent at one of our November board meeting, and also the ongoing discussions in respect of the charter can continue. Final one in just in terms of the reason to reside, and we'll look to include this in future reports, and then once that's in, then we'll close that action off. There's nothing else to escalate from the log. Thank you.
Thank you. Any questions or comments on the action log? Simon.
I just wonder if Matthew and Tina could give us a quick update on how the charter's landing now. I know there's been a sort of a small launch. There were some complications obviously around the funeral arrangements for Her Majesty, but if we could just get a sense of where we are now and how it's going.
I'll pick this up if that's okay. So still lots to do, Simon, is the honest answer, to make sure this is embedded in our everyday practice. We have signed off though through the TGB our refreshed signature behaviours, which has a strong link to the behavioural charter, with that set of really important core behaviours in the behaviour charter. So that will working up how we combine both the refreshed behaviours and behaviour charter to embed that in HR practices going forward. So we have done the launch. We have issued posters and credit card size information across to all colleagues across the trust. I think it hasn't reached every area of the trust yet, so we're still working with the divisions on how we do that. This work will continue between now and the end of March, so it requires a maintained focus to make sure people are aware of the charter. We will likely need to refresh the wording of the charter to link back in with the refreshed behaviour. So I'm intending to bring this through to a board development day to make people aware of it, of the work we're doing.
Yeah, thank you, Tina, and thank you for the question, Simon. Matthew, you wanted to come in?
Yes, thanks, Chair. And just to note, we're not waiting before using the charter with conversations of concern with colleagues, because the reality is where we need to realign behaviours. We're starting to use the behaviour charter. I learned at my team meeting yesterday that one situation where that's already started. So this is all about making it real, isn't it, in terms of the way in which we behave and go about our work. So we'll certainly revisit that at the board development session, as Tina said.
Thank you very much, Matthew. Okay, so we'll take that for noting then. So moving on to the chair's report. You'll notice I don't have a written paper in this morning, so just wanted to just highlight a couple of things for which I think you'd be interested in. I mean, obviously we've got a lot going on in the trust, and we've got some very important and serious things we need to discuss. But I did want to first of all just start by, yet again, we continue to have a challenging time in the trust, and really I'd really like to personally pay tribute to our staff for everything they're doing. Every day I come across an example of somebody trying to think differently, trying to think about what they can do, going the extra mile, not just doing sort of their basic job, but just thinking about that little bit extra. And at a time when everyone is so tired and things are so challenging, I have the greatest respect for that and the greatest pride in that. So first of all, just to say thank you again for everything that everybody is doing. And on that, there were just two lovely things that happened this week that I just wanted to flag as sort of, if you like, good news stories and things that we can be really proud of. Some of you may know that on Monday this week, we actually received a prestigious NHS England Pastoral Care Award for our International Nurse Recruitment Programme. That's one that's this is something that many trusts are doing around the country, but actually what we are doing is above and beyond. They aren't dishing out many of these awards. There was a ceremony at Kidderminster Hospital earlier this week, and it's great credit to the teams, and that was a team effort. So many people involved in that programme, so very many congratulations to everyone involved in that programme and for all the work they're doing. The second thing was Matthew and I had a lovely time on Tuesday when we had the chance to meet up with some of our longest serving members of staff. Members of staff that had completed either 25 or 40 years service, either with us or within the NHS. A lovely group of about 30 people on that particular occasion, all sorts of different job roles, sites, but an enthusiasm and a joy and a pride in what they do that shone through, which after 25 or 40 years was just really, really impressive. This is something we've restarted after a 4-year gap. So I think Matthew and I will be doing quite a few in the next couple of months to try and catch up the backlog. But it was lovely to meet these people. And again, my thanks to them and my thanks to the people in HR who organised that event, because I think it was very well received by the people that we were there. I'm going to pause there, and if there are no questions on anything I've said, I don't see any. Oh, Paula.
Thank you, Chair, and thank you for bringing up about Pastoral Care Award. As you can imagine, in the last sort of 18 months, I've been asked regularly for assurance on how we look after our international recruits. And I'm absolutely so proud of the team, of how they support these international recruits. And I meet with the international nurses regularly, where I thank them absolutely from the bottom of my heart, because this is no mean feat to come to another country, not just another country, and learn around the social and cultural aspects of working and living in another country, but the NHS speak and the jargon and the language that's used to get them to that level that they know. And every time I meet with them, I have never seen so many beaming, smiling faces. So I wanted to thank you for bringing that up, because that is really prestigious for us.
Yeah,
Thank you.
Absolutely agree. I try when I can to get down there and meet the intakes myself, and totally support everything Paula says. They're a fantastic bunch of people that are doing something that most of us could not contemplate doing ourselves, and that they and the team that support are phenomenal. Richard.
Thanks, Chair. I was at the event, so echoing.
Oh, Richard, could you speak up? We can't quite hear you.
Okay, I'll try shouting, Chair. Is that better?
That's a lot better. Thank you.
I was also at the event at Kidderminster, and it was wonderful to meet so many colleagues. I think also worth noting, we're now starting to see colleagues from our earlier cohorts at that intake starting to get some really positive career progression in different parts of the organisation, and also starting to take lead roles in supporting new cohorts as they come through. And it's just really nice to see that we're not just welcoming these colleagues in and supporting them, but also nurturing them and seeing their careers progress with our organisation.
Completely agree, Richard. And it's testimony that we're finding the right people, we're helping them fit in and grow and develop. So yeah, absolutely agree. On that, I'm going to move on to Matthew for his report.
Thank you, Chair. Good morning, everybody. I think the comments are all well made, and particularly the point about paying tribute to our staff, because again we continue to be under really quite significant operational pressure, as most of the country is, from an emergency, and obviously looking to recover our elective waiting lists. And again, we've seen a peak this week in wave 6 now of the COVID response, with on Tuesday 100 inpatients across the 2 sites. Started to see a reduction in that, but the operational implications for that have also been quite significant from an infection control perspective, and we have been working with ICB, Integrated Care Board, and Health and Care Trust colleagues to resolve some confusion with regard to infection control practice and sharing the risk in relation to that, and I'm hopeful that we've now closed that down. But I think there's no doubt the continuing challenge around ambulance handover delays as our key quality improvement priority, I suspect we'll be discussing later in the meeting. But I remain personally very concerned about the continuing challenge that the system has, and making sure that the system response is as positive as possible. I'll take the couple of points I just want to draw out from the report. Obviously, the development of our local integrated care system and the board that oversees it continues, as the report says. I think nationally there continues to be a big discussion about what is the key contribution and value added that an integrated care board can provide, and what can be done at integrated care system level strategically that makes a difference to the people that we serve. So those conversations are ongoing, and a particular area for us is in terms of the stroke service provision, making sure that we have a seamless pathway, and I'm in active conversation with our Health and Care Trust colleagues about how we move forward in that regard. We continue to keep our MPs as up to date as we can to help them to respond to constituent questions and concerns, and we're continuing to invite colleagues in to show them the work that we're doing and the way in which we're approaching challenges. We had some the chair and non-exec directors from the Health and Care Trust in for a visit earlier in the month, and this week we had a couple of colleagues from the Midlands regional team in for a walkabout and a conversation with our teams, which again is all part of us making sure that we're getting both clarity of the things that we're doing to improve things, as well as getting the appropriate support. In regard to improvement, you'll see that the Warwick Business School report on the Virginia Mason NHS England partnership has been published. I think I've said that round to all board members, and next month we will have an update report that talks to the things that we're doing in order to respond to the key findings of that report, and I'm going to include those in my regular stakeholder briefing note to help our partners to understand the approach that we're taking to improvement and culture change as well. I think, Chair, the worrying additional worrying thing in all of the things in my report is the spectre of industrial action as we go into winter. There's no doubt that the environment is already stressed, and the prospect of industrial action across a number of professions is a serious concern for us. And we have a planning group in action already to prepare for a number of scenarios and to make sure that our emergency response is as strong as possible, and to anticipate bringing a paper to board next month for assurance on the plans that we have in place to respond to industrial action. It's worth remembering, for those that can remember the junior doctors strike, there is no requirement for members of staff that plan to strike to notify us of their plans, but my experience elsewhere is if we get our engagement right with groups of staff, that makes it a partnership conversation as we lead into industrial action, as opposed to the last thing we need, I think, is any sense of conflict or adversarial relationships with any of our staff side colleagues, or indeed any of our staff. And that's the approach that we're taking, getting alongside our staff side representatives and our staff to understand the way in which we can best protect our patients and other staff during this likely industrial action coming in the next few months. And then finally, just to note, we're in the final stage of confirming appointment to our Chief Finance Officer, and with the imminent, in the next 6 months, departure of our Chief Operating Officer and our Chief Nursing Officer, we are embarking on the recruitment process to those replacements as well, and happy to update on that as that progresses from this week onwards. So happy to take any questions, Chair, or any comments. Thank you very much.
Thank you, Matthew. Richard.
Thanks, Anita. Matthew, you mentioned in your note the integrated partnership meeting that took place, I think, last Friday. Maybe you can comment on how that went. And the second point you also addressed in your words is around the industrial or potential industrial action. Clearly, that's a big concern. It's good to hear the taking precautions. I'm sure we're not alone in this, though. So is there anything happening on system, region, national level? Could you maybe comment on that?
Yeah, thank you. Thanks, Richard. I'm not a member of the Integrated Care Partnership, as it happens, so the providers are not part of that. So we're members of the Integrated Care Board, but I can certainly find out the key headlines from that meeting, Richard, and get a note circulated via Joe Newton's team if that's acceptable. And it looks like Tina's hands up in response to the industrial action point, as one would expect. Thanks, Tina.
Yes, so we are sharing intelligence at system level. So there's a fortnightly meeting in place for that. And there are regular workshops at regional level to make sure that we're aware of the legal implications, etc. So we're linked into both, Richard.
Thank you, Tina. Waqar.
Thank you, Chair. My first question has already been asked by Richard around industrial action. If I can just ask Matthew about the Warwick Business School's review of Virginia Mason's work in 5 hospitals. I mean, how successful, in your view, have Virginia Mason been in those 5 hospitals in terms of meeting their targets for efficiency, quality, and productivity? And what do you think that means for us, really?
Yeah, it's a good question. I mean, I think the report talks to some of the key characteristics that have led to perhaps a greater level of success at Leeds, Coventry, and Surrey and Sussex than at Shrewsbury and Telford and Barkinghaven and Redbridge to date. And I think some of the points referenced in this summary in my chief exec's report are, I think, the key things for us that we need to take note of. I think we're better placed perhaps than some organisations, given the 5 years that we've been working on our forward culture change programme. The evidence from the other trusts suggests that previous work on culture, I think, has been important. I think also a key point is the leadership culture change, moving away from executives acting down and fixing things to moving to more a facilitative coaching style, I think is something that we've been actively discussing in our Transformation Guiding Board meeting and others, and plays into the forward behaviours phase 2 and the behavioural charter. And I think also that sense of continuity, visible leadership is also something that we're also discussing as well. As I said, Waqar, I think what we aim to do is to bring a bit more detail to answer your question through the subcommittees on our board meeting. But I think we already had sight of the draft report from Warwick Business School, and we've used that already, those key recommendations, in the development of the forward improvement system.
Thank you, Matthew, and thank you, Waqar. Okay, if I don't see any other hands, so everyone's happy. So we note your report, Matthew, thank you very much. And let's move on to the 3-year plan, and I think that's Jo.
Good morning, everyone, and thank you, Chair. So we're pleased to bring our 3-year plan, our strategic plan, stepping forward for approval today. It provides a strategic framework to deliver our services to 2025. You'll see from the paper that the strategy centres around our strategic pyramid that we've already referenced, putting patient first, with the vision and our 4 objectives, which fulfil our aim to provide best services for our communities, and as a leader both in the health and care system, but also a valued integral part of the wider economy. Now, the strategy, you'll see, has been updated to reflect the impact that COVID has had at trust level, as well as how we have and will respond to changes in national policy and ambition to meet the national standards of service, delivery and care. This is also within the context of an evolving system framework in which they're developing an integrated care strategy and the 5-year forward plan. I'm not going to go through the plan, you'll be pleased to know, but there are 4 key themes within the plan, which are on page 16 or in page 38 of the pack. And these really focus on improving the quality and services. And this isn't just in terms of patient care, but also by investing in capital and digital infrastructure and getting some of our basic systems and processes right. Second one is around improving access. The third one around healthier lives. And the 4th one around financial stability. And clearly this strategy is underpinned by delivering of all of our enabling strategies, and indeed the forward improvement system that we've just heard referenced, which is helping support our cultural change. The plan's being developed with involvement and support from all divisions and corporate teams, and that again is detailed in the paper. And the format that we've got is really to try and have an accessible document that we can distribute and share with staff, with our stakeholders and with our communities as well. I just wanted to note that you'll see that the environment in which we're developing does remain somewhat fluid. We recognise there is further work we need to do in terms of some of that engagement. And this is going to start this month with Leadership Strategy Summit to really bring to life with patients, stakeholders and our staff how we can effectively build on and deliver this plan. And we're mindful that actually the next phase of this part of our strategic roadmap is going to be the underpinning medium-term financial plan, and this is under development, and Neil may want to comment on that. So just to summarise, Chair, I think it's true we have been living in unprecedented times during the COVID pandemic, and this strategy is brought today to enable us as a trust to refocus on our medium-term priorities, and acknowledging that over the coming months we will need to continue to work to involve with our staff and system partners and our patients our longer-term strategic ambitions. So it is brought here for your approval, and I seek that approval from board members there. Thank you.
Great, thank you, Jo. I was actually just about to call on Richard as chair of F&P committee to comment, and I see he's raised his hand. So, Richard.
Thanks, Anita. So, first of all, I'd like to commend the piece of work which took place in a very difficult period. I think it has become a good quality document that really clears our strategic direction. It is a strategic document, and that's also where some of my concern lies still, and Jo knows this, and this is also what we discussed in finance and performance. So I've got two points really. One is how do we plan to communicate this? I think it's a really important document. It provides some of the clarity. How do we plan to communicate this to all different types of stakeholders? The second thing is, since it is a strategic direction document and we have not really done our medium-term financial plan and we have not really done all the vetting with our system partners, what are we going to do if our assumptions around the fact that this is going to be financially sustainable is not going to be true, or if we see that some of our system partners cannot live up to the assumptions we've made in the plan? So those are the 2 points.
Jo, do you want to come back on those?
Well, Chair, would you like? Yeah, I can come back on those 2 points now. So I think you're right that actually this is setting the direction of travel, and clearly we need to be able to build on the medium-term financial plan piece that Neil may want to reference to. I think the whole plan has been built using information and in collaboration with stakeholders and patient groups, and information that was at hand. I think what is true is that we haven't been able to go about it, as you've referenced, in terms of the operation environment we've been in the way we might normally do so, in terms of having those face-to-face opportunities to be able to develop the plan, which is why actually the event on the 9th of November is really important to us, because it just helps us to test and sort of build on what we're doing. And actually we are having to be a little bit flexible in terms of the broader strategic picture, just because of these other elements around the system, as the ICS strategic planning pieces come into force, the guidance of which is still a little bit fluid. So I think Matthew might have put his hand up as well.
Yes, Matthew, did you?
Is that okay, Chair?
This
yes, it's specific to the question of our partners. I mean, I think colleagues that were around will remember that when we launched and did our stakeholder engagement activity on our clinical services strategy, there was perhaps more radical or new ideas that were being proposed, and greater clarity than there'd been perhaps before at that point on the role of each of the hospitals. I think my sense from talking to stakeholders and particularly ICB colleagues is that there is less contentious content in this, or certainly less new ideas. It sort of frames really what we talk about with colleagues very, very regularly. So we will, as Jo said, make sure that we get patient involvement as planned on the 9th of November, and continue to discuss and debate the direction of travel. But I'm not anticipating there being any major contentious points. The question then in terms of the medium financial plan, term financial plan, and the risks associated with that are likely to be more of contentious territory, I think, because we will be wanting to play into the ICB Finance Forum, to look at the work in relation to the left shift, looking at where people are receiving care, what are the consequences for our hospitals in relation to people perhaps coming into care or not going out of care appropriately. Those things, Richard, I think are perhaps a little bit further down the track, likely to be more contentious than really the strategic framework that Joe set out in the document. Hope that's helpful.
Thank you. Simon.
Sorry, Anita. The question about communicating this to all different groups.
Sorry, Richard. Yeah. So as I referenced earlier, with the format of this, it's a format that we will be asking our communication team to help support us with, so we can put it into a publishable document that we can then share with our stakeholders and make available through our usual routes with our patient and communication teams. So it is intended to be a document that can be shared and used.
Can I recommend you do a little bit more than that, certainly also with staff, and make it far more active and engaging than that?
Yeah, point taken. Thank you, Richard.
Thank you. And Simon.
Just like to echo Richard's comments about the difficult environment that this document's come into being through, and your comment a couple of times, Joe, of being fluid. I think is quite a charitable description of the different timetables and target dates that you've been dealt with sort of internally and COVID, and then obviously by system partners and nationally as well. So I think it's a product of that environment. I'm happy to endorse it here today, and I think it has some very good stuff in it, particularly around staff health and wellbeing, around our full improvement system. The enabling strategies, being estates and facilities, a very important one that we're looking to do more work on with the Finance and Performance Committee. But in particular, that point about access, one of the 4 priorities, and how we give real substance to that we make our services as accessible, particularly to those who currently can't access them as easily as they should do. So I look forward to working with colleagues on that as well as we move forward.
Thank you, Simon. Wakar.
Thank you, Chair. Which has already talked about the medium-term financial plan, so I won't comment on that. But this seems, Joe, like a 3+2 plan. The 2, we will get in light of what ICB's 5-year strategy is going to be. So my question really is, we worked very hard in difficult circumstances to produce this plan. Will the strategic framing change in light of the 5-year plan that we will need to adapt? That will come from the ICB.
Waka, I can never say never, but we've been very careful to make sure this is consistent with long-term priorities and the ICS development plans and the outcomes framework that have been and is being actively developed. We're also mindful and worked with the outcome of the Joint Strategic Needs Assessment and the health and wellbeing strategy that's being developed. So we've made sure we are consistent. And just to give assurance, we do have regular discussion both at place and at system level with Director of Strategy partners to make sure we have got alignment where we can. So notwithstanding any changes in national policy, then the assumption should stand.
Thank you, Joe. Thank you, Wakar. Julie.
Thank you. I mean, Joe, I think you introduced this in saying this is a sort of sense of direction, but for me, if I was a member of staff reading this, what am I going to do differently tomorrow? How am I going to implement some of this? Because it's broad aims. When are we going to see detail behind how we're going to do some of this stuff?
So I think, Julie, this represents a document that, as I said before, is trying to be accessible to an awful lot of different constituents. And one of those is with the staff. So we've worked very closely with the divisions in terms of developing through the specialties and in terms of what some of that detail might look like. And actually part of what we need to do going through the next stages will be to cascade this down into the divisional plans and then down into the operational plans and then ultimately the personal objectives as part of that golden thread. So I think for this type of document, it does feel, relatively high level, but actually, it will then get ported and translated down as we work back with staff in the divisions.
I mean, it is very, very high level, and the detail is not there. So I'm not actually sure how, if anybody, nobody could disagree with any of the overall aims and objectives there, but there's a lack of detail about how we're going to achieve them and how it's going to be different. So I look forward to getting that detail coming through, because it is, there's no one can argue with it. And I also think, though, that it needs to be set in the context of where we are now in terms of the nation's finances, industrial action, cost of living and everything else, because this is a plan that would stand in different times maybe, but the whole thing about workforce, when today's news coming out about 50% of consultants looking to retire or take job breaks and stuff, how are we going to deliver against that backdrop? I just look forward to getting the detail. Can't argue with the overall aims, but it's difficult to see how we're going to do some of this.
Chair, I know Matthew wants to come in, but I just wanted to, so in Appendix 3, we've actually had that start in terms of actually looking at what some of the milestones are, but if I might suggest, because I know it's something that F&P were interested in as well, it might be something to take back through F&P committee to provide that assurance of further detail.
Joe, on Appendix 3, I couldn't find it in the pack in VBR. So one of the things I was going to ask was about the measures of success and the timeline and stuff. So I'm assuming there is a missing page, but I don't seem to have it in my VBR.
Okay, I need to ask. Don't know whether Rebecca can confirm or not. We can make sure we can circulate that after the ball. Thank you.
Okay, I think Matthew wanted to come back on that point though. So
yeah, thanks, Joe. Yeah, I mean, I think as Joe says, there is in Appendix 3 that we've certainly seen some more detail in that. I think the exercise in the afternoon on the 9th of November, I hope we'll get into kind of that conversation that Julie you're alluding to, which is how are we going to do some of this stuff in the context, how and when do we approach particularly the issues of workforce and industrial action and other points. I think it's also worth noting that, of course, the quality and patient safety component of the plan has already been seen and approved by the board with really quite clear measurable objectives and metrics underpinning it. So that I think is all set out pretty clearly. Of course, the direction to travel on the digital element of it in terms of timetable and so on is also quite visible, I think, in the organisation in terms of the electronic patient record and the rollout of that. So I think there are elements of really quite specific detail. The area that I think needs a little bit more work then is how we turn the assumptions around workforce and finance into a clear implementation plan, which we're hoping to get into the business of that starting on the 9th of November.
Thank you, Matthew. Richard Haynes.
Thank you, Chair. It was really just, I think a number of the things I would have said about communications in answer to Richard's earlier question have already been picked up by colleagues, but it is bringing everything back to the pyramid, as we heard you do so eloquently at the start, but also to ensure that in the conversations that we are all having with the organisation and in the support we are giving to our leaders at all levels, these things aren't seen as separate but as different chapters of the same story. So it was encouraging to hear, for instance, in our patient story earlier, that it came from a Genva visit. So that ties in the patient story to the forward improvement system. We discussed that transformation guiding board last week, ensuring that reflections on the pyramid and our strategic purpose are part of the leaders training that is given for forward improvement system practitioners. There is a conversation that we will all be having this afternoon about the well-led component of the CQC review, and clearly part of demonstrating that is that we describe our leadership actions and behaviours as aligned not just to the pyramid but to the aims and objectives of the 3-year plan. So it presents, in answer to Richard's question, an almost infinite number of communications opportunities, but it is heartening to see that the things we've talked about since really we built the pyramid as a board and linked the pyramid to the clinical services strategy to the annual plan to divisional objectives to team objectives to individual objectives, and back again, is starting to come together. But it brings a number of challenges in articulating that in a simple, accessible way and linking it back to all the other things. But it's encouraging to hear colleagues in different parts of the organisation spontaneously starting to link those things together, and it suggests to me that certainly around the forward conversations, and this is why I'm so pleased with the way that the forward engagement has gone, people are starting to link it together. We need to do a huge amount more to really embed that and help our people and our partners and patients and the public to understand that. But all of these conversations we have do have that consistent thread running through, which I think is a strong foundation to build the ongoing communications and engagement activity on.
Thank you, Richard. Richard Ooster.
Thanks, Anita. Thanks, Richard. I that is encouraging. I think that if you ask all the people on the floor the same question, they wouldn't naturally come up with that answer. Yeah, so it's really important we keep using it. I think with regard to Julie's concern, that was definitely a concern we've discussed at FNP as well. We've agreed we needed a bit more flesh on the bones, even in the appendix that we can't currently find, and then also revisit some of it when we detail into the further plans. This is a strategic direction. Yeah, and I think that's always the challenge when you make these types of plans. That's why I mentioned my appreciation for the work being done. I think it serves well as a strategic direction. To execute, it requires more, and that still needs to be put in place.
Absolutely. Thanks, Richard. Sue.
Thank you, Chair. I'm probably not adding a great deal other than putting my voice forward to echo some of the stuff that's already been said. I just wondered what I couldn't find any operations input into this plan, so I agree that this is a strategy document, not a planning document. It's beautifully written, very nicely presented, but it doesn't tell me anything about what we're going to do. And I have to echo, I can't remember who said, if I was a staff nurse, a senior staff nurse on a ward, I don't see how this plan makes my life any different, or gives me any understanding of what I need to do next. It doesn't read like a plan to me, I'm afraid.
Thank you.
So what is the operations input into it?
So, Joe, did you want to come back on that point specifically?
Thank you.
Yes, I would do, and I think this is the understanding difference. I think Richard put it beautifully, just in terms of actually, just in the strategic framework and actually, operationalising a plan. So the divisions have been involved at different points over the last year or so. I think different people have referenced, the journey of producing this has been compromised at times by the operational pressures. But we did do a huge piece of work a wee while ago in terms of developing self-assessments that had the involvement of all the divisions and the specialties as part of a bottom-up approach. And actually, as Matthew, I think, has referenced, a lot of the detail in terms of how we're going to operation in this is captured in some of the enabling strategies. I think it is an inevitable problem with a strategy that's trying to look at things long-term, that actually some things that are more immediate come up and sort of have hit us that we have to sort of try and manage. So we do need some agility around it, but for sure, this doesn't sit on a shelf on its own. It has been co-developed as much as we're able, and part of the reason on the 9th is we wanted to reset so we can make sure we get the operational divisions back and focused in terms of how we're going to deliver it.
Thank you, Joe. Tina.
Yeah, just to say that we have taken quite a few iterations of the People and Culture section through both the TME and the People and Culture Committee. So year one, we've agreed 7 priority actions. So we have got an operational plan for that section, and we regularly report on our progress against those 7 priorities. The year 2, we obviously need to refresh those in the context that everybody's talked about today, but also to triangulate the People and Culture section with the other sections to make sure that it is aligned. But we have got evidence of how what's going to look and feel different in the next 3 years as a result of the actions we're going to take.
Thank you, Tina. Neil.
Thank you, Chair. I take all the comments on board. I think it's a huge piece of work, isn't it? There's lots of components to this, and I think we need a much more detailed project plan around how they're all going to interface and link together. I think the enabling strategies are emerging. I think just going back to one of the comments that Julie's mentioned there, I think what we are working on is projecting forward from a top-down perspective what the state of the nation's looking like, both from a financial perspective, but also what the expectations are maybe around what the targets might look like. And I think from there, what we've struggled with in the past, I think, is articulating that from a demand and capacity perspective. Have we got sufficient sufficient capacity to address the expected level of demand? Where is that from a productivity improvement versus additional capacity? How does that play to workforce? And what are the financial implications? And again, balancing that with the top-down financial expectation that we're going to have over the next 3 years of it being a hugely challenging outlook. We are in the process of developing a demand and capacity model that's linked to, again, an emerging financial model. That over the course of the next month or two, we're hoping to get to a point of clarity on, so what does that sort of bottom-up meets top-down picture look like? I think we've got all of these components then, so how do we fit all of that into that model? What are the implications of each of these enabling strategies and these plans in a bit more detail? I think that's what we're missing, is a huge piece of work in all of that. But that's what we need to be pushing through over the course of the next couple of months, of course.
Thank you, Neil. I don't see any more hands, and I think we probably, I'd like to bring this one to a close. I think in summary, what I'd say is I think that this is a paper, as many have said, that this is a well-written, thoughtful strategy framework that I think none of us would argue with. I think that what I think the comments of my colleagues have shown is there is absolutely an appetite for us to understand how we make this actionable. And as I say, unfortunately I didn't have Appendix 3, so I was thinking, well, how are we going to measure success? How are we going to see progress? So I think if that could be remedied, I would certainly want to see the missing pages. But I think there is something about saying that we do need to make it actionable. And I have one other sort of word or suggestion for the team. As we know, and it's even more apparent now than it ever was, we cannot deliver this strategy without the collaboration and support of system partners. We have got to make sure, at the end of the day, we see a patient, we only see a patient for part of their journey. And I really would encourage the team, as we start to think about how we make it actionable, please let's look at how we can co-create those bits so that we have, what we do not want is by decisions we take to have unforeseen consequences in another part of the system. We need to look at this in a cohesive and integrated way. So absolutely, we're looking, good progress so far. We want to see the actionable bit. How are we going to make this real? We want to see how we're going to measure progress, and we'd like to see how we can demonstrate that we are working with our partners on this to actually make this actionable, because we're not doing this in isolation. We can't do it in isolation. But otherwise, I think a good report. Thank you for that. Can I get, we're being asked for approval of the 3-year plan. Are we happy to give that? Yep, I'm seeing some thumbs up. Joe, thank you very much. Please thank the team for this piece of work. It's a good one. Thank you.
Thank you.
Right, moving on then to the next item on the agenda, which is the South Midlands Pathology Network strategic outline case. I think that Mike Corns has, I think I've seen him on the gallery, so welcome Mike. Thank you for joining us today. I don't know, Joe, are you kicking this off, or who's going to present this one? Or is it Christine? Sorry, Christine, is it you that's presenting this?
No, I think it was myself just to introduce, and then I'll hand straight to Michael. So,
perfect.
So colleagues may recall that as part of the emergence of networks and mutual aid, that there's been an initiative to develop a South Midlands pathology network across what are 5 trusts in effect. As a requirement, we've got a programme board that's been stood up with representatives from all of those constituents, and one of our colleagues on the gallery, Richard, is chairing that programme board. In order for us to sort of get the work and engage with it, there are 2 items that we need approval for at our board today that have already gone through approval at the other acute trust boards, and these are the papers we're seeking approval for today. So I'll hand to Michael to give you any detail and answer any questions. Thank you.
Morning all. Thanks for the invite. So as I said, I'm here to look for approval for 2 strategic outline cases, both relating to the formation of the network. And just for information, it's just gone through the Y and Coventry boards and got approved, so in the last few days. The first of the 2 strategic outline cases relates to the formation of the network itself, and the second one is for a single instance of a LIMS to replace all of our LIMS, which would support the formation of the network. As Joe said, while the network currently isn't formed officially or legally at the moment, we do have that stakeholder board with the exec representation, and we did agree at that we have already proceeded with work on the outline business cases at risk from that meeting. Again, as Joe said, the original drivers for this were related to the Carter report, then reinforced by the Richards report and GERFT, and then NHSE have created 29 networks across the country, replacing, I think it was like 119 individual pathology labs. All of these networks are at different stages in their formation, and NHSE are very keen for us all to get to the maturing status by 2025. In terms of what the network will deliver, I'd quite like to describe it from the patient perspective, and what we're aiming to do is, and I think actually from a patient perspective, establishing a network will probably provide a service that patients probably think we already do in terms of interoperability and connectivity between the trusts. So what we aim to do is get a scenario where a patient can be under any consultant across the network, but can be bled at a place convenient to them, with results being available to whichever consultant they're seeing, wherever they see them, and this will avoid them having to be re-bled at the trust where they're seeing a consultant potentially, or as we currently have to do, generate a PDF and email it across from wherever they were bled, which obviously is has transcription risks as well as is being time consuming. And not only that, by forming a network, we'll be able to harmonise and standardise what we do so that any sample taken anywhere in the network will follow the same high standard that we would expect, and we will look to use evidence-based to produce the kind of best-in-class pathways for all of our samples and cascade networks. As a network also, we'd look to collaborate and work together to realise efficiencies, do a bit more innovative work, a bit more research and development, and work with other clinical teams across the entire patch to produce evidence-based pathways that are using what we can do in pathology with the clinicians to create the best pathways we can. In addition to that, it should deliver financial benefits, it should improve resilience, and all of this will lead to improved recruitment and retention by making us an employer as a region that people want to come to. And we're already working on looking at strategic recruitment pathways to try and boost how we can bring people into the network via different mechanisms. So just to touch on the 2 SOCs independently as a quick update on where we're at. So the network one, as Joe said, that's 5 trusts or three organisations, because CWPS represent the 3 Coventry trusts already, and they're already like a mini network. But we're at the stage at the moment where we're pulling together a clinical strategy group or a clinical senate to look to develop what the vision for the network would be over the next 10 years, and following that we will then pull together some operational colleagues to try and look into how that will be delivered, and there's a view for the outline business case for that to be delivered to boards around May, June of next year. For the LIMS strategic outline case, timelines are a little bit tighter. Having the LIMS is a key enabler for the network. It really is the key bit that will drive and glue us all together. It's also worth noting out that actually do nothing isn't really an option, because all 3 limbs are at or beyond end of life, which is particularly an issue for Worcester, which we have a bit of a dead stop around 25, 26, as we're discussing at the moment. It's worth pointing out we put in a bid as a network with NHSEI for interoperability funding, which we were successful in receiving, and that is currently due to be delivered over 23, 24 and 25 and 24, 25. And that was an interoperability fund, and our aim is to use this capital to fund the project, and we're looking at, as we'll come out in the OBC, to capitalise as much as we can, with an aim to keep the revenue as close to current as we possibly can. The OBC, we were initially looking to get that by the end of this month, but it's looking like it'll probably be the end of November that will come through, with a view to starting the procurement in December. And just as a bit of I won't go into the timeline detail, but we're then looking to have all the contracts and everything signed and awarded by the end of the next financial year, so that we can make that first payment using the NHSEI money, with a view to go live from the first system somewhere between 12 and 18 months after that, because that is the length of time it will take to build these systems. Clearly it's not a project without risk, but I think the risks are all being worked through and will come out in a lot of detail in the OBC, which you'll receive shortly. I think I'll stop there and take any questions on it.
You're on mute.
Apologies. Yes, thank you very much, Mike. I know this has been through finance and performance already, and I don't know whether Richard will want to comment. Oh, Richard's hand's gone up, but Christine was in there first. Christine.
Thank you, Mike. I think the paper articulates really well the clinical and operational benefits of being as part of a network. I just wondered whether you could say something about whether being part of this network will improve our education and training offer for our staff and the possibilities for career development.
Yeah, I mean, it's work we're already starting to work with. We've already appointed a regional education coordinator, and we're working very closely with them to see how we can use apprenticeships, how we can bring in the experience of, for example, from my own profession in biochemistry. We're looking at, we haven't got experience as a trust of bringing through STP trainees, but Coventry and Warwickshire have, so it's how we can work together with them, and Wye Valley in the same boat, so perhaps we can bring trainees through here. And we're looking very closely at how we can use things like apprenticeships, and there's quite a lot of funding being made available for that sort of pathway. So on the clinical side especially, there are some clinical apprenticeships coming through, which we're very much looking to utilise, and I think as a trainee, if we can share what expertise each site has and have trainees moving around the network to use that expertise, it will make us quite an attractive place for people to come.
I'm sure that's true, and I really support that.
Yeah, thank you. Yes, I had the pleasure of meeting Mike a couple of weeks ago when I went down to pathology, and we talked in detail about that, particularly that aspect. And I think it, given the sort of recruitment and retention issues, I think that it could have a real benefit there. Richard.
Thanks, Anita, and I think Mike, really good introduction. Thanks very much. The rationale is very clear, and I think Christine has also added to that rationale. Makes total sense. I just wanted to say, first of all, the funding of the OBC work is done by the region, if that was a concern of anybody. And secondly, the collaboration is really good, and it's very clinically led, which is the only additional remark I would want to make. So yes, FPC supports it, and from a personal perspective, I really support it as well.
Great, thank you, Richard. Matthew, to sum up.
Yeah, thanks. I mean, I think this is both of the documents. Obviously, the LIMS is one that it feels as if we have to progress with. I think my reflection, we go back a few years, and Mike would have been on this journey along with many of his clinicians. The prospect of getting to this point in terms of the relationships between the organisations at a clinical level, at a managerial level, I just think this is another example of our broader clinical teams really stepping up to do the right thing, to develop a proactive constructive relationship with other partners in the context of putting patients first. And I think it's often the case that, you know, people think, you know, that doctors and clinical scientists and other people are inflexible, but I think this is a really good example of our teams really stepping forward and taking a leadership role in bringing the 5 partners together, and I think it's an important additional point to note for the board.
Yeah, thank you very much, Matthew. Right, so I think we've heard everything we need to today. These strategic outline cases are for approval. Do I have the board's approval? Yep, I see thumbs up. Great, thank you very much. Mike, thank you for coming along and sharing this with us, and the best of luck.
Thank you.
Thank you, bye-bye. Right, moving on, we have Complaints and PALS annual report. Who's interested? Is that Paula? Paula, perfect. Over to you.
Thank you, Chair. So just to note, this has gone through the varying committees and obviously the subcommittee QGC as well, where it was obviously sent on to board for approval. I'll take the report as read. It offers an assurance level of 6. I just wanted to call out a couple of issues. In 2020-21, we had a 69% response rate. That has now achieved in 21-22 above 80%. We had 578 formal complaints, of which is probably about the right number for this size of organisation, but 2,290 compliments, and I realise that isn't actually the correct number, because during the years we're not getting all of the compliments recorded because the staff sometimes don't have time to do that, so I know there's much more compliments that are going on as we speak. The issue I've got sometimes is when we don't hit the 25 working day response rate, is some of these complaints can be quite complex and run across a couple of divisions, and we just need to negotiate a little bit more time with our complainants at the start of the process, and not think that we can just let that run over the 25 working days. So we're just working with the divisions on that now. But that's all I really wanted to draw out of the report. It's really well written, and I would like to formally thank Alex Marshall for his comprehensive PALS and Complaints annual report. I commend it to the board.
Lovely, thank you, Paula. Absolutely agree. It's a well-written report. Any questions or comments from anyone? I don't see any hands, which implies it's answered all our questions. Ah, no, Simon, over to you. You nearly escaped there, Paula.
sorry to spoil the party, and I hope not to. I think the important thing of this is the lessons learned.
Yes.
And what we do with that information, and I know that is covered in the report, but Paul, I don't know if you'd like to say a little bit more about how that practically works and what we do about some of the issues that are raised, because I think that is the crucial thing about particularly the complaint side.
No, absolutely, and this is really important, isn't it, with regards to the fact that we've actually recorded that in the annual report, the lessons learned. So from a point of being of myself with the ward managers and matrons and the divisional directors of nursing, we talk about complaints and the themes every week and every month about what we can do. Obviously you hear some of those stories played out at board, and obviously then we talk about these things through our clinical governance group and onwards and upwards to QGC should that be needed. Often if we have a complaint that I think actually the ward staff themselves, where that complaint has been made, would be beneficial to see the patient or relative to talk to them directly. That has also happened. That is really impactful, because you can read a complaint and we can read an annual report, and we get a quarterly report as well. Is actually when you read that, it doesn't hit home sometimes, but when you actually hear the complainant come in, be it a patient or a relative, the staff then seem to take on board those lessons learned, and things have affected change. So one of the issues that we've had numerous times was around sleep and noise at night in the hospital, and how in the wards, and how we can address that. So obviously from that we provide sleep packs. We've looked at the issue around when I do my night visits, what the environment's like, how noisy the staff talk to each other. So we've managed to pull all that together from a lesson learned about a number of complaints that said it was too noisy and too bright at night. I hope that's helpful.
Thank you. Richard.
Thanks, Anita. Definitely approve the report. I think it's really good, and it also shows the progress we've made over the last period, which, you know, in all of the difficult circumstances that we've discussed. There are two things which we briefly also discussed in QGC. One is around how do we know this is good? We've compared to the past. That's one way of looking at it. How do we compare to other trusts? If we look at the amount of patients we treat, the amount of complaints we get, how does that compare? The second thing is a bit of a concern around how easy it is for people to speak up. Because when I look at the ethnicity percentages, it feels not in line with the amount of patients we treat from an ethnicity perspective. So they apparently have more difficulty speaking up, or I don't know what's really going on here, but maybe you can comment on that, and maybe you can do a little bit of work understanding that better.
Absolutely, and we can do that comparison. What we did say, didn't we, at QGC, was we would also compare the numbers from previous years in a table so that we knew if that had gone up or down, and that will go in the next quarterly reports and into the next annual report. So we're addressing that, so absolutely right. And we compare that with the same size trust about their numbers of complaints. I think we also alluded to, didn't we, in QGC about the population and some of our other population and cultures about how they are able to complain, and we invited Joe Rinshaw to see if there was any way we could, from Healthwatch, enable those other cultures to be able to freely speak and complain. And I know I told you I did a bit of work in my previous trust about how I went out into the communities to encourage them if they've got issues to bring up. And that is something we do need to probably work on here. And also from that point of view, we do have posters that are displayed about making sure that if you're not happy about any aspect of your care, and we do that anyway through wards and departments, because actually somebody being able to put pen to paper is quite sad for me as a chief nursing officer. What I really want them to do is address the issue at source. So if there's something in the ward or something in outpatients, so that we can resolve that at source. But obviously, if they can't, then they've got the opportunity of going to PALS, which is readily advertised. And if that's not successful, then they readily know how to make a formal complaint. And that's also on our website. So we do have posters up as well that says all of that. Do patients and staff or relatives read that? And probably not always. But I think the way that it's advertised in the NHS to be able to make a complaint has increased. And people, I feel people know how, but maybe that is something we can look at going forward.
Thank you, Paula. Thank you, Richard. Christine.
Thank you, Paula. I'd just like you to pass on my thanks to Alex for writing such an excellent report. It's a lot better than a lot of complaints reports I've seen going to boards, and I particularly liked the section on learning from complaints,
yes,
where it highlights some of the complaints or concerns that we've had and says what changes we've made in response to them. So I really appreciate that being in the report, so please thank Alex.
I will indeed, thank you.
Thank you, Christine, and I completely echo that. I think it looks like there's no more questions. So just to summarise, yes, I thought it was a great report. I really liked, and I wanted to highlight as well the learning. And I think so. And I think the questions regarding are we doing everything we can in terms of outreach to certain groups, perhaps who maybe find it, perhaps culturally or for other reasons, more difficult to put in complaints. I think it would be really good for us to make some progress in those areas. So I think that sounds like a great idea. But otherwise, a great report. Yes, please, our thanks to the team that put this together. Are we happy to approve the report? Getting nods, thumbs? Yes, absolutely. Thank you very much. That's approved. Brilliant. Okay, we are now moving into the integrated performance report, which I assume Vicky's going to be introducing. Is that right, Vicky?
Thanks very much, Chair. Yes, I'll do a very brief introduction. What I thought was, Chair, because there's quite a lot of detail in here this month as per normal, we'll let each of the executive directors dive into those bits that are required and any questions that come from colleagues. This is the IPR report for month 5. It has an overall assurance level of 4, and this remains unchanged since the start of this financial year. It has been through all of our trust management executive and our subcommittees of the board where various domains have been scrutinised. There was one change following the subcommittee at Finance and Performance where we actually changed an assurance level to 3 with the 62-day cancer standard, which acknowledged the number of patients that were waiting over 63 days for treatment. You'll also notice on page 137 of the board pack that we've actually included an appendix on the variation of performance icons and an explanation for people that just need that refresh. I thought that was quite helpful from the team to do that. In terms of key areas of focus outlined in the executive summary, these relate to the operational performance across all aspects of elective recovery and urgent care, and also the cancer challenges. Into quality and safety, we've got infection prevention control and also fractured necrothemia, which has been a recurrent theme for a number of months now. People and culture, we've got workforce challenges as we've explored previously as a board, particularly around recruitment and retention. Now we have seen some improvement around the number of full-time equivalents that we've got outstanding, and then our financial position, which I'm sure Neil will delve into in detail, and I'll leave it there if I may, Chair.
Thank you, Vicky. And before we get into the detail, can I just say, yes, I found the expanded sort of analysis or guide to analysis really helpful. I have to be honest, I then spent about 10 or 15 minutes testing myself on whether I got them all right, so it was hours of fun, or could be potentially. So no, thank you for that. I think that would be helpful for people that are less familiar with SPC. Right, so first section, operational performance. So Paul?
Yeah, thanks, Chair. I'll just give an update on the what I think are the 3 key areas, because obviously this report is somewhat old now, so I'll give a positional update to the end of September, covering cancer, elective and urgent care. For once, I'll start with a bit of good news in terms of our elective position. We will report next week no 104-week breaches in September, and board will recall that we'd already reported no breaches in August, and you'll recall that at the beginning of the year, April, when we look forward to March 23, we had 23,000 patients that would reach 78 weeks unless we dealt with it. And you'll recall that we set ourselves a target that by the end of September we'd reduce that 23,000 to 10,000, so we do more in the first half of the year than the second half of the year. We've actually overachieved our position, and the end of September is actually 7,667. As a consequence of that, we are in, as you know, tier 1, which is not where we want to be. That's the Dorsey class, if you like, for cancer and elective. We have a weekly meeting with the region as a consequence of that, and at our weekly meeting a fortnight ago, the region were positive about our elective performance and have said if we continue that for the next 3 weeks, then it's likely they'll make a recommendation to take us out of tier 1 for elective. That is not the same for cancer. I'll come to that next. So we're ahead of schedule, still got a lot of work to do to get to the 0 patients at 78 weeks by the end of March. But as I said, in the first 6 months of the year, we were targeting to reduce that by 13,000, and we've reduced it by over 15,000. In terms of cancer, whilst obviously we have to be focused on all of the tumour sites, there are 3 sites that are driving our position for 62-day and 104-day long waits, and they are the colorectal pathway, the prostate pathway and skin. We do now have a plan on skin, which we have implemented, and what we're now beginning to see is a stopping of the increase in the backlog, and that's been achieved through a mixture of additional activity and some mutual aid with colleagues from Wye Valley. So there's still a lot more work to do, but we now have a clear plan for skin. We have colleagues from the intensive support team for cancer on site today, and this morning we went through our plan for prostate, and I'm pleased to say that so far the team haven't identified anything beyond our plan, and the key areas for us are, if we are going to achieve this 28-day faster diagnosis target on the colorectal pathway, then there are two areas that we need to address. One is that we have increased the nurse-led triage capacity and also consultant clinic capacity, but you'll recall that the colorectal referrals have now gone up by 100%, from about 80 to about 160 a week. And whilst we've got the capacity now to deal with that predominantly through nurse-led triage, the booking capacity, the 2-week wait team do not have sufficient capacity to actually book the patients into those slots. So we agreed this week, I agreed this week to increase the resource in the 2-week wait pathway to resolve that, because that is a key blocker, and given that we've got all the clinical resource in place, that's the first issue, and we've got a resolution to that. The second issue is the time it is taking from nurse-led triage to booking and report either CT colonoscopy or colonoscopy. We now have our facilities at Kidderminster, as you're aware, fully operational, and what we've been talking about this morning is from next month that we use the extra endoscopy capacity at Kidderminster and hand that over to colonoscopy to prioritise. So this isn't an additional resource, let me be clear, this is having to prioritise between routine work and cancer work, and we're making the decision to prioritise that cancer work to provide additional endoscopy slots for colonoscopy, and we're doing the same with the CT scanner to provide additional CT colon. Plain CT for the small number of patients who cannot cope with the bowel prep for either colonoscopy or CT colon is functioning well. If we can address that, and so that within the pathway all patients who are referred are seen by the nurse-led triage within 3 days, and to ensure that the investigation and reporting of that investigation is completed by day 12, then we will get way beyond the national target for the faster diagnosis, and we should hit around 90% against the 75% target. And I have a commitment from all of the colorectal surgeons that if we deliver their extra diagnostic capacity, they will deliver the rest of the pathway to achieve the 28-day standard, and as a consequence of that, the 62-day standard will automatically be met. So we do have a clear plan for that. And then prostate, the main blockers there are clinic capacity, MRI capacity and biopsy. We've had discussions with our clinical colleagues. They have agreed to put on additional capacity, so they will start running, they started on Monday with the clinical teams running an additional, within cost and job plan, an additional clinic every day providing 8 slots for prostate review and an immediate referral to MRI, and we're allocating part of the mobile MRI that we have at Kidderminster to urology for prostate work. There's some more work to do on solving the biopsy capacity. We have a meeting. I had to drop off the board just towards the end to meet with the prostate team and the IST to go through that last element. So I think now that we will remain in tier 1 for cancer, but I think there's a confidence that we know what the issues are and we have a plan to resolve them across those 3 main pathways, which account for about 90% of our performance issue. I think if we can address that and demonstrate we can do it in a sustainable manner over the next 3 months, and that will be initially stop the backlog growing and then reducing the backlog. I think that gives us the potential by the end of the calendar, not financial year, to be considered to come out of tier 1 for cancer.
That's great. I'm just going to pause you there because you've covered a lot of ground in both elective and cancer, and just check if there were any questions or comments on what you said. I don't see any hands raised at the moment, but certainly in terms of those 2, it sounds like excellent progress on the elective work. So, congratulations to the team for doing that and getting down and hopefully, touch wood, getting out of tier 1 on that. In terms of the cancer, you've explained very thoroughly the issues, and as you say, we may not be there yet, but at least we have an understanding of what needs to be done, which I think is important. I'm just filling at the moment, just to see if there are any other hands, but I don't see any more. Oh no, Simon, there you go. Simon.
Is it okay, Anita, if I ask for an update on ambulance handovers and also ask Paul about discharges?
I'm just going to move into urgent emergency care. I just wanted to talk specifically about elective and cancer just before we move into that.
I'll wait.
Okay.
If I could just add, Chair, that once we finish this work with the prostate and the colorectal teams, what we're planning to do is to turn that into a detailed written plan with a trajectory for review by F&P and then oversight by F&P from November onwards.
Okay, great. Richard.
That answers part of my question. It's great to hear, by the way, these very specific measures to address one of the things that really concerns us a lot and is very patient focused. So I'm very positive about that. I also have to remind us that the total waiting list is still increasing, so we're making choices here, but we do have a lot on our plates too.
Absolutely, and I completely agree. Right, thank you. So, Paul, can we now move to urgent emergency care? I mean, the elective and the cancer are important issues. Obviously, the one that's getting a lot of focus at the moment is urgent emergency care. I wonder if you could just summarise where we are, please.
Right. So, as colleagues are aware, we did implement the North Bristol model. The initial first week of that saw a substantial improvement in handovers with a reduction of about 60%. We've then gone backwards over the last fortnight, where despite still pushing the model which is in place, we haven't had the desired effect. There is one other kind of technical issue that we did, as the board knows, create a cohort area, but because those patients are being looked after by a paramedic room, they count against us as almost as being on an ambulance, and that has shown us to be that's added to our numbers, but more importantly from an external review of our performance, because the patients are in the hospital, they're actually in the cohort area for longer hours, and that then is shown as us having long waits in ambulances, albeit that they're in the hospital. We've had a number of discussions with all the clinical teams about the way to handle that. I'm pleased, I was saying to Matthew earlier this week, I was about 90% confident. We had a final session with the teams yesterday, and I can now say I'm 100% confident that we have a plan for mid to late November, where we will be moving, as colleagues know, the AEC and the AMU into the first floor of the Aikenbury building as that gets handed over, and those moves will take place on Sunday the 13th and Monday the 14th of November. The AMU move releases the white space, and having had a number of discussions, but I can now say that that will become a multi-specialty surgical assessment unit that will cover trauma, general surgery, ENT and oral max fax, and will also include direct admission rights from ED into there without having to work up the patients, and will also provide a direct route for GPs when there's been a GP to registrar or consultant discussion. Those patients at the moment are landing in ED, they'll now go straight to this unit, and we're expecting that unit to be open about 10 days after we have transferred into the Aikenbury building for AEC and AMU. And I think that will make those moves, and that capacity will make quite a significant difference. The problem for us is I don't think anyone, both within the board, which is most important, but also externally, can tolerate waiting to mid-November to late November for that to happen. We've therefore had a number of further discussions, initially with Matthew, Christine, Paula and myself, and then Paula and myself met with the clinical teams again yesterday. So what we have decided to do, and we will be implementing this tomorrow, and it is a risk-based position, to be honest, is that we are going to increase the cohorting from the 3 spaces to 5, and we are going to take over from YMAS the staffing of those with our own staff, that we're putting extra shifts in place, and therefore I think the ED team, there's a risk here, but the ED team feel it's the least worst position. So we will manage those patients. So we will have a 5 cohort space instead of 3, and they'll be managed by our staff. So they will go off the clock and they will disappear from the reports that are viewed externally. I think I have to be honest. I think a lot of us are well, yes, I think we are a bit uncomfortable, but I think it's the right thing to do. It is for that 4 to 6 week period, because we've got to demonstrate that improvement. At the same time, we changed the North Bristol model this week, so we were moving patients over a 24-hour period from the AMU and the surgical decision unit into the base wards, and obviously from ED into those 2 assessment units. Following a discussion with our clinical colleagues, surgery wished to continue moving patients from their assessment unit into their wards over the 24-hour period, but our specialty medical colleagues felt it was, for them, it was safer and more effective to move the patients between 6 AM and 10 PM, so no overnight movements from the assessment units into the wards, but still the same number. So we're just bedding that in. We changed it on Tuesday morning, so we've only been running it for 2 days. I have to say, this morning there were no ambulances outside, and I'm sure Matthew can identify, he was on call last night. I'm sure there's no correlation between the two. So that's what we're doing. We're enhancing the North Bristol model with the change we made on Tuesday. We're making these changes for cohorting, but I would add that Dave Raven and team are still in intense discussion with YMAS to create the paramedic role for cohorting. It's just that the indication we're getting from YMAS in signing the role, which is a role that would not only oversee the patients but would start the workup of the patients. It's not a, for want of, I can't think of a better way of describing it. It's not a babysitting role. It's a clinical role and workup. We're looking to sign the job description and the MOU off with YMAS colleagues tomorrow, and if we do that, YMAS, they're saying it will take about 4 to 6 weeks to recruit to the paramedical roles to take on that. And again, we don't have 4 to 6 weeks, which is why we made the decision yesterday to increase the shifts in ED so that we take over the management of that cohort area from YMAS tomorrow, but then we hand it back once the paramedic roles have been recruited to. And because when we make that change, the paramedic staff will be seconded to the trust, then again those patients in the cohort area will not be, to put it bluntly, they won't be on the clock. So we're doing an intermediate solution of taking over responsibility for the cohort area and increasing the space from 3 to 5 for this 6-week period, which is a mixture of moving to the enlarged assessment units and for having the seconded paramedics in place. So those are the actions that we've agreed predominantly, well, since Monday and Tuesday.
Right, thank you, Paul, and thank you. I mean, I can only imagine that these have been very difficult conversations and very difficult decisions that have had to be made. Clearly, we understand the drivers. Clearly, we need to be, we all need to be assured that that this is safe, that the quality of care for patients is not impacted, and so on. And I'm sure that that's that will have been uppermost in everyone's minds during these discussions. Let me open it up. Matthew.
Yeah, thanks, Chair, and thanks again, as always, to the urgent care team and Paul, Christine, and Paula's interventions to move this forward. I mean, it's important that the board recognises, and I'm sure everybody can extrapolate from what Paul said. This obvious point is that these changes are not designed and are not going to lead to an improvement in the patient experience. And the reason for doing it is very much, in my view, as the accountable officer, to buy us some headroom from the level of scrutiny that the teams and I are exposed to at the moment, to make sure that we plan effectively for when the first floor move into Aikenbury happens, to allow our teams to really focus on getting the same-day emergency care, the ambulatory care provision, the frailty point that we talked about earlier in the meeting, get all of those elements which will make a difference to outcomes and patient experience to be properly planned for and therefore successful when we make that move. If we hadn't made some interventions now, I think that headroom would have been, and that space to plan would have been quite difficult given the level of scrutiny that we and the teams are under. But I think it's important that the board recognises that in effect this is increasing the number of patients that our ED team needs to look after by 5 on top of already a very significant demand and compression in a very small a poorly designed emergency department. We've rehearsed that before, and that's why we're re-providing it in the Aikenbury building. I just want to stress that point. This is the least worst option, but we need to be mindful that this is not going to enhance patient experience, and we need to make sure that we're monitoring how our safety systems are in place to ensure that both our patients and our staff are not coming to harm as a consequence. Thanks.
Absolutely, and I'm sure that was very clear to me from what you said, that those are exactly the risks that the team is balancing, and I certainly understand the context in which you've taken the decision you have. Okay, Richard.
Thanks, Anita, and thanks, Matthew. Totally understand what you're saying, and I completely share the feeling of discomfort with this decision, knowing that this is the best of the worst. I do think we also do this for the system and the citizens in Worcestershire, because we want to keep the ambulances available as much as possible. So it is really important also from that perspective, which is maybe not our patients yet, but could be our patients. So really important to highlight. The thing, Paul, that kind of is a bit that I'm wondering about is we've been implementing the North Bristol model. At first we saw some good success, some good progress, and now that seems to have deteriorated. Do you know why that is? Do we know the reasons for this?
So I think on some occasions, because we haven't seen the level of discharging that we needed, and we've actually come in early in the morning to being unable to move the number of patients we've set per hour because we've actually fully boarded. So yesterday morning, when Paul and me were reviewing the position, by about 6:30 yesterday morning, we had double boarding on every one of our wards. So we had 18 patients boarding. We had to stop the movement from the assessment units to the wards because there was nowhere else left. So we have had a challenge in there comes a point where we can't move any more patients because we've all the beds are full and we're double boarding on all of the wards, and we've had to stop the model. That didn't happen in the first week. We kept the flow going, so we are working on how we can better secure the level of discharging that we need. And to be fair, that is both simple and complex pathway discharges to allow that flow to continue throughout the 24-hour period from ED to the assessment units. And then, as I said, we just changed the model this week so that for the medical, from the medical assessment to the medical wards, that's now running between 6 and 10. And of course that's created more pressure in some ways because we're moving the same number of patients between 6 and 10 than we were previously trying to do in the 24-hour period. So it is to be frank, Richard, we haven't achieved the number of discharges we needed to allow the model to continue to flow, and that's what we're working on trying to do, and we're looking for support from our system partners around that, and we're picking that up. Matthew kind of highlighted that at the Home First board on Tuesday, but then we're following that up with some requests to our partners that we're going to put out in form in writing tomorrow.
Okay, because that's what I was afraid of, yeah. And anything we do without solving that problem is only going to buy us a few days more, and then we're getting stuck in the same problem again. So I think we, as a board, we would really like to understand better how, with our system partners, we're going to solve this. Otherwise, we cannot solve the problem ourselves.
Yeah, absolutely agree, Richard. And as I say, I'm also having conversations with the chairs across the system and with the ITB chair, and every conversation we have we come on to this. And in fact, we raised it also when Matthew and I hosted the region representatives a couple of days ago. We raised it again in that conversation too. So I think I'm starting to get that there is greater recognition and acknowledgement of the fact that they need to do something, which in the early days, frankly, I didn't necessarily feel that. I do feel that there is that, but then translating that into something that is going to make a difference to us, I think that's where we're kind of in that grey area, right? Simon.
Thanks, Anita. I'd like to just give you a couple of real case studies and show how difficult this can be at times. One or two colleagues may have heard me describe this already, of an elderly relative of ours who's 84, who was admitted to Avon for a week. And on a Friday morning was due for discharge. She was medically fit for discharge, and I went in to see her there that morning, and the occupational therapist said to me, we have a very, very small care package in place for her to go home. This was early on a Friday morning. The OT actually put her fingers together and said it's very small, and then she can go home. That care package was not put in place in the course of the whole day of Friday, which resulted in that relative spending the whole weekend in PDU, patient discharging it, when she could have left. I'm not decrying the efforts that were made to get that care package put in place, but it wasn't put in place during a whole working day. And that meant a bed in PDU was effectively blocked for somebody who was ready to go home. Similarly, when we had our colleagues from the Health and Care Trust, the non-exec directors, come on a tour, and we went around AMU, a member of staff said to us as we were going around on that tour that they had a patient who needed a mental health bed who'd been on AMU for 9 days. The reaction of the non-exec directors from the Health and Care Trust was quite one of surprise. One of them actually said, I thought we had resolved this issue. But clearly there was a patient there, again, who was not appropriate for us, who needed a different bed. But again, the system, for whatever reason, was not able to work with us as well as we'd want it, or they would want it to. So there are real examples of how, despite our best endeavours, at times limited capacity or abilities within the system makes our life more difficult than it should be. And just on the case of the cohort, I was able to have a conversation with a paramedic who had attended to that elderly relative when she was admitted, and that paramedic had spent a 12-hour shift in the cohort area 3 and said how well it was working, and that she actually enjoyed the experience of being there with those patients throughout that shift, and that it had allowed 2 ambulances to effectively move on and support other people within Worcestershire. It just seems a little counterintuitive that that was actually counting against us in terms of how the figures are calculated, because the ambulances were released. But I know this is not a perfect system we're operating within, but I thank Paul and Matthew for the updating on where we are, and we are moving in the right direction. And North Bristol itself found it quite bumpy in the early days for themselves to get it working appropriately. But I think there was a call to arms to system partners to really understand some of the limitations, some of the problems that are caused when we can't discharge people to the right place. So, more power to your elbow, keep at it, and particularly you, Chair, keep talking to our colleagues in the ICB so that we can all work together on this, that the system works better to support us so we can get people to the right place at the right time.
Yeah, absolutely, Simon. Now, we've got a lot of questions, and this is an important discussion, so I am going to carry on. Though, can I please can we have an eye on the clock, and so can we be as succinct as we can, because we've got a long day ahead of us, and we need to finish on time if we can. So, Neil, you're next.
Yeah, thank you, Chair. My question's in respect to finance, but just very briefly in terms of picking up there from Sam, I think it's about visibility and transparency of information. I just wonder whether there's any learning from Bristol in terms of that out of hospital aspect, and whether it made any of those changes there that we can maybe come from. But from the perspective of finance, Paul, I just need to be clear on this. Is quite dynamic, isn't it, in terms of all of the changes, and I just need to be able to track the finances and just make sure that the within the winter funding allocation, there was no expectation of spending it twice. If we could maybe pick that up outside, that'd be great. Thank you.
Thank you, Neil. And yes, if that could be picked up outside, that would be great. Paula.
Thank you. And just to provide the board with assurance around the quality and safety of those patients that are boarding in our areas, there's a whole governance framework wrapped around that process to ensure any incidents or complaints are recorded and we act upon them immediately. And also when I am provided with data and the acuity of the patients, and particularly in an area last week, I halted the boarding process on that ward because of what had happened on that ward. I need to make sure the board is fully sighted. This has impacted on our staff, but also the fact that the ED staff are also taking on an extra 5 patients, given the fact that they grat outside on the ambulance as well, and that you know, those walls are losing their elasticity now for that stretch. I just wanted to make sure that everybody knows that the staff are being affected by this, but they are still doing it.
Yeah, absolutely, Paula, and I think that, you know, it is. Yeah, this is very hard, very hard. Christine.
Just a couple of clinical points on the subject of why it's not been completely effective introducing the North Bristol model. We've got both quite high levels of COVID and we've got flu in the hospital at the moment in Worcester, and that's and therefore for infection prevention and control reasons, that has impacted sometimes on our ability to move patients through the system. The second thing is that we've often, as you will know, we often decompress the Worcester site by diverting to the Alex. Our ability to do that has diminished over the last couple of weeks as the Alex has had very high levels of bed occupancy, and in particular the number of patients who've been in the Alex for more than 21 days has increased, and this shows special cause variation.
Thank you, Christy. Yes, indeed. Okay. I think we would have to say, note, you know, the board is generally not wholly comfortable with what we are asking our staff to do, but we recognise that, as others have said, this is a case of choosing the least worst, the lowest risk situation when we look at the pathway as a whole. And as others have said, I think being able to release those ambulances to go out and respond to other people in need is an important one. But we absolutely acknowledge and recognise that this is not, these are not decisions that any of us would be wanting to do. Right, very quickly, if I may, Tina, the people and culture, is there anything that we'll take your report in the IPR as read? Is there anything you want to draw to our attention, please?
Yeah, just briefly, conscious of time, but the focus has to remain on recruitment and retention, because obviously making sure we've got the right workforce to deliver our priorities is the key. We are 68 whole-time equivalents up in months 1 to 5, so as staff in post. However, that will still remain 82 whole-time equivalents down against our plan. So we have increased our recruitment activity and continue with our retention schemes. And we are seeing improvement in the time to hire, and that's as a result of the recruitment value stream and focuses on those processes. So we've been working with the divisions. We've refreshed their workforce plans, so we're really clear on what we need to recruit to maintain our workforce plan for this year. And we have around 200 to recruit. We've got 360 roughly in the pipeline. So we do believe it's achievable, our workforce plan. However, that only will keep us standing still. So we're trying to improve on that plan to reduce our vacancy rates even further, but that's in the context of quite a challenging labour market. So that's just the key points to highlight, please.
Thank you, Tina, and your comments are noted. Thank you. I don't see any hands. Neil, can I ask the same? Could you just give us the headlines, please, in the interest of time? I think we'll have read what we've all read your paper in detail.
Sure. Thank you very much, Chair. So year to date, pretty much on plan, just slightly over against the plan at 8.8 million deficit. Much the same story as previous month. We're off track on PEP. On our productivity and efficiency programme, 2.4 million adverse to plan, and that's largely being offset by underspends on our developments and non-recurrent benefits. So we're storing up a problem for the future. I think in terms of the position will be challenging for the next half of the year, particularly looking at the PEP. There's still an element of ERF risk, still an unknown as to whether we're going to get that funded into baseline without risk. Clearly we've got winter and developments. I'm looking to bring a mitigation plan to Finance and Performance Committee in the next couple of weeks, and then onto the board. I'm happy to take any questions, Chair.
Thank you, Neil. I don't see any hands raised. Simon.
Just to echo Neil's comments about the PEPs, they are an ongoing concern for us in the Finance and Performance Committee. We discussed at length a new approach to next year's PEPs. We have to get these right early on, that they are actually mature schemes before we sign them off, because we keep signing up to schemes which ultimately have not reached a level of maturity to be delivered, and puts us in a very difficult financial situation. And I'm not being critical here of colleagues, but I think we just need a harder edged way of approving PEPs in the first instance, because this year is going to be very, very challenging, as Neil has alluded to.
Yeah, absolutely, and I think certainly for me, it's the PEPs that I'm most concerned about actually at the moment, and your comments make in terms of having a different approach to them going forward, I think makes a lot of sense. Matthew, did you just want to wrap this up?
Yeah. I mean, I think the other thing, obviously, that we know earlier in the year we were asked to stretch our plan in order for the ICB submission to be less than 1% of overall turnover. Neil, do you want to quickly summarise where we are at system level? Because there are particular pressure points in the system that aren't related to acute providers on this occasion.
Yes, so the ICB is showing some significant overspends in respect of continuing healthcare. Big challenge for them this year. I think it's been a massive increase since 2019-20. Weighing ourselves at this point in the year broadly similar, just slightly over plan. The ICB, I think, is showing some risk in respect of its financial position, some significant risk.
Thank you. All right. If everyone's happy that we bring this discussion to a close, the IPR is for assurance at a level 4. Are we comfortable with that level of assurance? Yeah. Okay. Thank you. I know that was there were some very important, very difficult issues we needed to discuss there. My thanks to the executive team for the decisions they're taking in real time to try and manage the situation we're under. So thank you for that. Okay, moving on then to the committee reports. Again, I think if I could ask each of the chairs to just highlight the key things you wish to draw to our attention, that would be helpful. So first off, Richard, Finance and Performance.
Thanks, Anita. I think the report is quite comprehensive. I would repeat the concern about PEP, but also the concern about not spending on our business cases, because that is really how we kind of impact the future on this. So I would kind of urge and emphasize Neil's words that it's really important we do a very thorough forecast for the remainder of the year and highlight all the opportunities and risks and the mitigation of those, so that we can then actively manage the next part of the future and hopefully set ourselves better up for next year.
Absolutely agreed and noted. Thank you, Richard. Fine. Quality governance. Oh, sorry, Simon wanted to come in.
Sorry to be a pedant, but the report records that we met on the 29th and 30th of September is actually the 28th and 30th of September, just a correction.
Thank you, Simon. I didn't actually notice that and thought that was a bit weird, but anyway. Okay, quality governance. Julie, anything you want to particularly flag?
No, everything's been picked up in the main book, and that goes for the next one as well, the people and culture. I think the execs have highlighted the main issues.
Right, thank you very much for that. Moving on then to nurse staffing. Again, in the interest of time, if we could have key points only, that would be brilliant. Thank you. Paula?
Thank you, Chair. Absolutely, this paper's gone through TME and People and Culture. It offers a level of assurance of 6, where we've dropped that level of assurances on vacancies, but we're still modelling favourably against the model hospital data, and we're obviously continuing the recruitment drive. Sickness has increased, which we would have seen because staff are tired, and also COVID has increased. And obviously then also turnover, especially HCAs, where we are, healthcare assistants, about where we are trying to not only recruit and continue to recruit, but to retain, and we're looking at a plan with regards to how we retain those staff and value them, and I'll commend the report to the board.
Thank you, Paula. Any questions on the nurse staffing report? No? Assurance level of 6. I think we are comfortable with that. Thank you very much. Moving on then to midwifery staffing. Is Justine on, I think?
Yeah, good morning everybody. So this is the staffing report for August, level 4. That's been unchanged for the majority of this year. I'm happy to report that I am doing the next month's report, and I will be recommending a higher level of assurance finally. So just going back to this report then, we had an increase in births. It was a busy month. We therefore reduced the times that we were able to meet our acuity without making those management changes and actions that you're all familiar with. There was some red flag reporting, the no harm incidents. You can see there's some increase in fill rates, and that was in response to the incentive offers that we were in terms of pay, which is good in August to see. That really did make a difference and kept us safer. Sickness is down and turnover is also down. The new starters that you'll see outlined in the paper did start in September, and that is why we'll be able to report more favourably next time we all meet. And we've also recently heard that we have been awarded financial support from an international recruitment bid for midwives, 6 midwives hopefully that will come on board in the next 6 months, and hopefully we'll be able to deliver that level of pastoral care that our nurses have already seen, and retain those staff. So I'm going to end there on, although I know it's not, we're still at level 4, but just giving you that assurance that very soon you will see those changes and actions that we've been talking about for so long coming to fruition. Thank you.
That's great to hear, Justine. Thank you. Simon.
Thanks very much, Anita, and thanks to Justine as well. And just to echo what she said about the improvements, I think, that are coming through. Paula and myself and a couple of other colleagues did the maternity safety visits this Monday. It was noticeable, because of the higher than usual staffing levels, that the body language of colleagues, staff, was better. It felt calmer, and I think that's very helpful, those staffing numbers going up. The increased use of the Meadow Suite as well was being well received by our colleagues. We have a target of 40 births there for this month, and we were at 15 already on Monday of this week. So, fingers crossed we are moving in the right direction. I look forward to the report that Justine will bring on September's figures in due course. But for somebody who goes round maternity once a month, looking at babies for an hour every Monday, once a month, it was noticeable, and that's great. So please do keep it up. And colleagues I know there are working very, very hard and making a difference. So I just thought I'd make those comments for you.
Yeah.
Thanks, Simon.
Thank you, Simon, indeed, and thank you for your work as the maternity champion. I think that's been really helpful. And so we look forward to the next report, Justine. But thank you for a positive note there. Level 4 assurance, I think we're happy with that as a board. Thank you very much. Right, moving on. We've got 15 minutes. Responsible officer report. Is that Christine? I wonder again, Christine, can I ask you to let's just pick the sort of the highlights of things we need to know, and we'll take the paper as read, please. Thank you.
Yeah, so it's a requirement of my statutory role as the responsible officer of this organisation that I produce an annual report to provide the board with assurance that our appraisal and revalidation system for doctors is functioning as it should. I think the report does provide that level of assurance. It needs to be signed by the chair of the trust or the chief executive to say that it's been approved by the board and submitted upwards to NHS England to my high level responsible officer.
Thank you very much, Christine. Thank you. I think it was a comprehensive paper, so I think it covered all the base, certainly the questions I had. It's here for approval, level 6. Can I have the board's approval for that, please? Nods. Okay, thank you. That's approved. Thank you, Christine. Moving on. Board assurance framework. Rebecca.
Yes.
If we could deal with highlights in the interest of time, that'd be great.
Yes, no, absolutely, Chair. I draw committee's attention to the summary page on page 194, which shows the overall movement. There have been two increases in risk score, both of which reflect the discussions that we've had today. The various committees have reviewed and updated the risks aligned to their areas, and the detailed board assurance framework in full is within the reading room. We've made some minor amendments to the formatting of the summary to draw out one of the improvement recommendations from the external auditors to include the target score in the summary, whereas previously it was only in the full detailed report. The position reconciles with what we heard throughout the meeting, and I'll pause for any questions. Thank you.
Thank you, Rebecca. That's a great summary. Any questions or comments on the board assurance framework, and particularly those changes in scores that Rebecca has highlighted to us? No? Okay. Matthew.
Yeah, sorry, Chair. I'm just reflecting back on my earlier comments for the board in relation to industrial action. I wonder if we can take an action away just to reflect with Tina and others on the risks associated with that, because they could be really quite significant. So sorry, Rebecca, probably not helpful making that comment now, but it is one of my key keeping me awake at night concerns. So I wonder if we can take that away as an action. Thank you.
Yeah, it's absolutely fine, and this is why the BAP is live. It's not a document I just give to you every quarter. It's supposed to be iterative, so it kind of proves the process. Absolutely, thank you.
Yeah, absolutely. So thank you, and yes, indeed, a concern certainly. Audit and Assurance Committee. I know Colin isn't here. Simon, are you able to bring to our attention anything that needs to be brought to our attention, please?
I think it just reads for itself. If there's anything specifically I'd like to raise with you, I'm happy to answer any questions, but I think we're on track with as far as audit insurance is concerned.
Perfect, thank you. I don't see any hands raised. We'll take that as read. Thank you very much. That therefore brings us to, and thank you all of you for your efforts to try and bring us back on track, which I very much appreciate. Apart from anything, for some of you know, I'm on a substitute laptop and I don't have the cable for it, and it's about to die, so I'm hoping I'm going to be able to get to the end of the meeting and then charge it before we start our next meeting, but we'll see where we go on that one. Any other business? I don't think we had anything noted. I don't think there's anything that has come up from the meeting. So I think it leads me really. I'd like to ask Jo Ringshall as our representative of Health Watch Worcester. I don't know if you had any comments or questions related to anything that you've heard today at our meeting, Jo.
Not particularly. I was very pleased to see how focused it was around patients. I mean, the patient story was lovely, and I suppose my concern is when Matthew was talking about the patient experience with the additional cohorting and the boarding, and I was just wondering what sort of things have been put in place or could be put in place to actually mitigate against that. I mean, is there anything that can be done?
A very valid question, and I'm sure that's in all our minds. Matthew, would you like to answer, or would Paula or Chris?
Well, I wonder if
Paula's raised her hand.
Yes, because I know that we've really focused, and I know Paula's focused with the team on the importance of nutrition, food, comfort, etc. So perhaps Paula, if you'd like, is that all right?
Yeah, no, that's fine. And you're absolutely correct, Joe. The patient experience is something that will be affected and has been affected. And it's that communication element, isn't it, to those patients, especially when we're boarding, and to explain the rationale for that. But also alongside all of the care and attention that's required to look after those patients normally, whether they're boarding or not. But also we've got 2 quality matrons, and making sure that they're doing quality rounds as well, and that's being recorded. We're also stepping up internally our unannounced visits into certain areas so that we can see them in a different light, and obviously our night visits continue as well. So, but I'm sure there's much more we can have a look at. But I am meeting with my senior nurses this afternoon, and we will be discussing patient experience as well as safety and quality.
Thank you, Paula, and thank you, Joe, for your question. If there are no other closing last-minute questions from anyone, I'd like to draw this meeting to a close. Thank you very much to everyone who attended, our board members, our guests, and indeed anyone watching the stream. We will be moving out of this one and moving straight into the corporate trustee meeting. So I wonder if we could move straight away into the next. We don't have to leave this link, do we, Rebecca?
No, we'll just follow through. Thank you, Chair.
Lovely, thank you very much. Okay, so then moving to the papers for the corporate trustee. Let me just get back to my beginning. Right, so we are now meeting as corporate trustees of the Worcester Acute Hospitals charity. We have apologies for absence as before, Colin Horwath. Declarations of interest, we have those already as previously on the website. Minutes of the meeting held on the 9th of June 2022. Do we have any comments or requests for changes to those minutes, or can we take those as a true record? Okay, we'll take that as a record, as approved minutes. Thank you very much. We then get to the charitable funds report. Simon, I think that's you.
It is, thank you, Anita. I'll take the report as read, but just to highlight for you that, as in the executive summary, that we have had our final accounts and annual report dealt with appropriately. We were working with Bishop Fleming, a local firm of accountants who audited our accounts for us. The committee spent some time discussing cost of living support for staff and decided to make a decision to allow or make provision for £15,000 potentially to be used for meal vouchers. The report that came to the committee was talking about a lower figure than that, but we decided that a higher figure was more appropriate. And just to confirm that we have now committed funds to the robot, as was always envisaged, but it's nice to be able to report that that is now actually happening. And as you'll be aware, Anita, many of the non-exec directors will actually get to see the robot on Monday when we are meeting at the Alex for a meeting amongst ourselves. So progress to report, but happy to answer any questions on the report that's in front of colleagues.
Thank you very much, Simon. Any questions? Richard?
First of all, thanks, Simon. I think it's great to see that we are actually spending some of the money for really good purposes. But it is a little bit concerning to me that our costs outweigh our income in 21 and 22. Can you maybe comment on that? It also seems a bit high, the cost.
Yes, we have discussed that before in the committee, not specifically at the last committee meeting, but it was over a couple of meetings where we were looking at that. There are a number of reasons related, I think, to COVID, with the drop-off in donations and money that we were raising, in part related to COVID. I don't know if Richard would like to add anything else to that, but we are on top of it, we're aware of it, and hoping to turn that round in the next financial year.
Only to add what you've already said, Simon, we're working in a very, very challenging fundraising environment. That's feedback from not just from our team, but from other NHS charities, and in fact the whole of the third sector. As Simon will be aware, what we are doing for the first time this financial year is we have clear income targets for each month. Those are being mapped very carefully and reported back to charitable funds. And we are just about ahead of target so far year to date across the piece. So that's giving us much greater transparency in Charitable Funds Committee on income versus expenditure on a regular basis.
Thank you. I just have one sort of, so thank you for that. I have just one sort of comment, which I'm sure the committee is already is very much top of mind, given the challenging circumstances that many of our staff are in with cost of living and working conditions generally. Just want to encourage the committee to keep looking for ways in which we can support our staff in appropriate ways in which we can support our staff, because I think anything we can do to make the next few months easier, I think would be in my book would be money well spent. So I just want to just sort of encourage that conversation, which I'm sure is happening, but certainly you would have my support on that.
Yeah, so I think just to add on that, Anita, the report that came to the committee was talking about potentially £5,000 for meal vouchers. We decided that probably wasn't enough at the current time and made provision for £15,000, but it is an open-ended commitment on one level that if we need to go further and if we need to look at other schemes, we will do that. But it is a hopefully easy to use scheme that we're putting in place that staff will be able to find very straightforward, but we are on top of this and will continue to monitor what we can do as a committee and as a charity, and then recommend to the board if there are other things required on how we can support colleagues through the cost of living crisis.
Thank you very much, and that's exactly what I was hoping to hear. Brilliant. Okay, so in terms of this particular part of the agenda, we've had. Is there any other business from anyone with regard to the corporate trustee? No. Very good. So in which case, I should like to thank everyone again. We have a break now. Rebecca, remind me, when are we meeting back again? Is it 1 o'clock?
Yes, confidential session starts at 12. Resolution to exclude the public. Thanks.
Okay, right. Okay, so the board will pass that resolution that to continue our conversations in confidentially. So that we will pass that, and if everyone is happy with that resolution, we will draw this meeting to a close and we will recommence our conversations at 1 o'clock. Thank you very much for your energy and attention this morning. Onward and upward. All right. Thank you.
Thanks, everybody.
Bye bye.